Hello, and welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I'm your host, Rebecca Sapp. I'm a board-certified allergist and immunologist and a fellowship director who always enjoys learning more about the exciting field of allergy and immunology. Our podcast series will use interviews with thought leaders from the world of allergy to keep you up to date on new developments and to review core topics. Today, we'll be discussing latex allergy. Latex gloves were widely used to protect healthcare workers, and this led to an epidemic of latex allergy amongst healthcare workers as well as patients that we're still managing today. As allergists, it's important to understand the history as well as how to manage latex allergy today. Today, we are pleased to welcome Dr. Jay Slater to discuss latex allergy with us. Dr. Slater is a board-certified pediatrician and an allergist who recently retired as the director of the Division of Bacterial, Parasitic, and Allergenic Products in the Office of Vaccines at the FDA. He started his career as a pediatric allergist at Children's National and continued practicing there throughout his career. His research interests have included latex allergy, as well as the characterization of non-standardized allergen extracts. Dr. Slater, thank you so much for taking the time to join us today.
Thank you very much for having me. I'm looking forward to it.
So we'd like to start by getting to know our guests a little better. Could you tell us a little bit about yourself and maybe include something you like to do outside of medicine?
Oh gosh. Well, I better get better at doing things outside of medicine because I recently retired from my job at FDA. I'm a pediatric allergist and immunologist. I started my career at Children's, as you said. I was there for 12 years. And it was during my time at Children's that I was introduced to latex allergy, which we're going to be talking about today. It was a big moment for me. And to be honest, it gave me the opportunity to do more research, which I've enjoyed a great deal. It also gave me an opportunity to get my job at the Food and Drug Administration, which I took in 1998. And it was a real change in my career. As you said, I've continued to see allergy and immunology patients throughout, but my day job has been largely regulatory and research based. And contrary to what you may think, the regulatory stuff is wildly fascinating and a lot of fun. And it was a terrific career. And I turned the direction of my research away from latex allergy towards issues that were more important for regulation of allergen extracts and vaccines. In terms of interests outside of medicine, my life has been really, really, really full. I've had, well, my wife and I now have between us 10 grandchildren who keep us quite busy. And we have kids and lots of people who we're very proud of in our families. And we look forward to spending more time with them.
Great. And what brought you into allergy immunology as a field initially?
Oh, gosh. Well, I was a pediatric resident at Columbia Presbyterian. People out there in the audience who did their peds residency at Baby's Hospital, as it was known then, will recognize that it was an extremely intense program. As interns and residents, we had total responsibility for our patients, and the sort of star specialties there that we were most drawn into were peds cardiology, peds neurology, ICU medicine, really sort of intense fields. Allergy and immunology seemed to me to be a field that was consistent with primary care, was consistent with really taking care of people who weren't necessarily sick enough to be in the hospital. It was also a field that was clear back then, and this was, in the 1980s, was going to be a field that had a great deal of growth potential during my career, and that's actually borne out. Allergy has really improved a great deal. We have a lot more to offer our patients, and it's been incredibly satisfying, and it continues to be.
So, latex allergy has kind of emerged on the field in the 1980s, and it was really kind of this dramatic recognition of an allergen that could really cause severe reactions. Can you tell us a little bit about the history of latex allergy, how it became this kind of healthcare epidemic?
Yeah. It's actually super interesting. It's a very good question. It really brings together a lot of different social, scientific, sociologic factors all at once. Latex is a natural product. It is generated from the sap of Hevea brasiliensis, which is a tree that is native to the Americas. And the potential for latex to be used in waterproofing really was initially recognized by European colonial powers. There was some initial efforts to make raincoats by coating cloth in raw latex. The problem was that raw latex was really very brittle and not very durable. The invention of vulcanization, which is the process by which the polymers that are in latex are cross-linked using heat and in the presence of sulfur, really radically changed the universe of latex as a commercial product. The other thing that was critical in the development of latex as a commercial product, and this involves, as you can imagine, the exploitation of natural resources and human resources by the European powers, was the development of huge plantations of latex trees, Hevea trees. These plantations were owned by companies called Goodyear and Firestone. They were using them in large measure to feed the growing need for rubber tires for cars. But they also were being used to develop rubber products of all sorts. So, from the earliest days of rubber products, there were people who had dermatologic reactions to them. In general, looking back on these, they were, for the most part, very likely to be contact dermatitis reactions to chemicals that were used to make the rubber products and to stabilize the rubber. That said, there were, and I don't remember how early it was, but certainly early on in the 20th century, there were isolated reports of what appear to have been true IgE-mediated reactions to various rubber products. And these were to gloves, which, embarrassingly were not used that often in the early 20th century in medicine, but were starting to be used, but to other kinds of rubber products that were used in the dental field, for example. In early 1972, I think, there was a report by Nutter from England of a pretty clear-cut case of contact urticaria to a rubber product. And it really was many years then before the next series of reports came out of Europe in the 80s. And these were all anecdotal reports. And some of them were pretty well studied. I mean, I think the idea that latex allergy sort of popped up in the late 1980s is untrue. I think it clearly was there before. But what happened, of course, in the 1980s was, because of HIV, a much greater interest and demand in latex products being used as barriers to infection. Universal precautions was invented during this period. It led to a tremendous expansion of manufacturing of largely latex gloves, both sterile and unsterile, for this reason. Now, we can get back to this in a few minutes, but the manufacturing of latex gloves and condoms and balloons in particular have had certain features to them that made it more likely that some of the protein antigens that were originally present in the tree would persist into the final product. And we can talk about that more. What happened to us in children's, and I was a junior physician at Children's Hospital at that time, was well, to be honest, I had sort of been looking for a research interest. I had just left my fellowship at NIH. I decided that I was going to get into drug allergy. I knew nothing about drug allergy. It was a totally fanciful idea that I would learn something about drug allergy and do experiments and contribute to the field. So I let it be known among all the other doctors at Children's Hospital that I was really interested in seeing their drug allergy patients. And it was a very collegial group. And it wasn't long, I guess it was 1988, when I got a call from one of the anesthesiologists that they had just had an episode of anaphylaxis in an 11-year-old child with spina bifida. And they resuscitated the child. And of course, they had given her many different drugs that were known to cause anaphylaxis, antibiotics, paralytics, succinylcholine. All of these were well known to cause intraoperative anaphylaxis. I had two excellent fellows at the time, Jerry Shire and Jim Maddy. And I don't remember which one of them went to speak to this patient's parents, but they came back and presented the case to me. This was a child with spina bifida who was having a revision of a ventricular peritoneal stent. And they, said they had done a fairly good history and it was a fairly uninteresting history, but they did note that the parents said that the child was allergic to rubber. And when we went in and talked to them about this, they said that the child had had a repeated history over a period of many years of having hives and in some cases wheezing when exposed to balloons and in the dental chair. And we sort of parked that because we didn't know what to do with that information. But we did a complete workup, at least as complete a workup as we could find, to the other agents that we thought were likely, and we ruled them all out. And we sat down and talked to the parents, and they said, "Thank you, that was very nice and thorough, but we know what caused it. We know it was caused by the rubber that she was exposed to during the surgery." They were absolutely delightful, but quite insistent that they knew that was going on. So we parked that idea, and then I think it was within 2 or 3 months that the anesthesiologist had an almost carbon copy case with another 11-year-old girl with spina bifida, who this time was having a tendon lengthening procedure, anaphylaxis during the surgery. Same exact story, same history. It was actually kind of eerie. Oh, I scratched my head. This is the days before PubMed. I had come up with some case reports, but not many. I didn't know what to do with this. Actually, in DC at the time, we had a really excellent monthly meeting of all of the allergists and fellows in the DC area at NIH on the campus. I presented these two cases to people and I said, I really don't know what caused it. And both sets of parents seem to think it's rubber. What do you guys think? And all of these very, very smart, experienced people in the audience kind of scratch their heads and say, I never heard of anything like that. That sounds crazy. So we went back and got samples. We called up a rubber company, I think in Akron, Ohio, and they sent us a jug of ammoniated latex, which I opened up and it smelled really strongly of ammonia. And I really didn't think that allergens were going to necessarily persist in this. So I was trying to find a way to get pieces of rubber trees that I could grind up. Somebody ultimately directed me to the US Department of Agriculture, which had a plantation essentially, but a research plantation in Puerto Rico. And I reached out to some guy there whose name I'm embarrassed to say I don't remember because I should have thanked him in our first papers. But he was very interested in this. He told me that there were some workers in the latex groves who got allergic reactions, and he actually sent me a whole bunch of plant material. So we had plant material, largely leaves and twigs. We had the ammoniated latex. We made some sterile extracts out of them. We skin tested the kids. We did very nice basophil histamine release experiments with both of their basophils. We stripped control basophils and resensitized them with our IgE. We showed very nicely that this was truly an IgE reaction to proteins in the latex. And that sort of exploded things in the United States. It got very prominent coverage. And all of a sudden, people were noticing this quite a bit. Because of universal precautions, the group that actually numerically had the greatest risk of reactivity were not children with spina bifida or even children with other repeat surgeries, but rather healthcare providers. And that's where the sort of latex allergy epidemic really occurred. And that occurred in the 1990s.
I just have a question. Are latex and rubber the exact same thing?
That's a good question. No, they're not. Rubber is basically a flexible elastomer. It's a lay term. It's not a scientific term. Even latex can have multiple meanings. Latex is the liquid material from which you make rubber, but you can get latex from several different kinds of plants. The Hevea brasiliensis tree generates a latex that, first of all, it generates large quantities of the latex. So it's very nicely useful for commercial purposes. It also contains cis-1,4 polyisoprene, which is the polymer that is cross-linked to make commercial rubber products. But there are other plants that make latexes or lattices, and those products are less commercially useful, but needless to say, they have other allergens in them. So there was an early interest in some of these other latex generating plants that they might generate less allergenic latex products. And then finally, you can make synthetic rubber products that have never originated from a plant, and those are now excellent products, but there were problems associated with them initially.
And what made latex such a good allergen? Why was latex the thing that everyone became allergic to, or
Yeah,
that caused such a strong allergic reaction when you were sensitized to it?
yeah. Now, I don't really know the basic answer to that question, but one of the things that I alluded to earlier was the difference in how different rubber products are made. I've heard of people who have allergic reactions to tires, but not much. Okay, it's pretty uncommon. The major offenders in terms of latex allergy are the products that are manufactured by what's called a dipping process. And in this process, a mold of the particular product is dipped into liquid latex. The mold is coated with chemicals that will contribute to the vulcanization, and the vulcanization then occurs at a relatively low heat. It's not particularly high heat toasted the way other kinds of products are generated. So the dipped products include gloves, of course, and if you go back in the literature, you can find pictures of glove molds being dipped into liquid latex. These are very, very memorable pictures. Condoms, balloons, and certain flat sheets of latex that were used at the time in dental procedures. There are times, let's say root canal work, where the dentist really needs a dry field to work in. And in order to keep the field dry, the dentist will pack the area around the dry field with what's called a rubber cofferdam. And that's essentially a sheet of poured latex rubber that keeps the area dry. And there have been lots of people who have had serious allergic reactions in the dentist chair. Even if the dentist is using non-latex or low latex allergen gloves, they can react to the rubber cofferdam that's used during the surgery.
And who's really at the highest risk of developing a latex allergy?
Well, it has to do with exposure. And so the two groups at highest risk are people who use latex gloves occupationally, and that includes healthcare workers, especially in the era of universal precautions and high latex allergen gloves. But it also includes people in the meatpacking industry, many other industries in which people need to be gloved, factory workers of all sorts, and occupational exposure probably numerically is the most important exposure today. In hospital exposure, that leads to sensitization tends to be limited to patients who undergo recurrent surgical procedures. The index cases that I took care of were children with spina bifida, but there are also children that have genitourinary defects that require recurrent surgery. Typically, exposure early on is more sensitizing, but sensitization can occur at any phase.
And what's the rate of latex allergy now versus we'll say in, 1992 when the kind of the peak of everyone was using latex gloves, particularly powdered latex gloves. How has that changed?
Yeah, I think it's gone down quite a bit. There really are a couple of things that have happened that decreased it. First of all, in terms of our patients, there was a much greater awareness that spread very rapidly in the pediatric surgical community. Pediatric anesthesiologists intensely aware that this was a problem that really could complicate their management of their patients and really affect their lives adversely. So I think pediatric surgery community, the anesthesiology community, hospital administrators really came together to reduce latex exposure in the operating room for the sake, frankly, both of their employees and their patients, but definitely focusing on patient safety. The original terminology was to make an operating room latex free. It was quite clear in a very short time to anybody who thought about this seriously that that was an impossible goal. Because latex allergens, especially on examination gloves, tend to be aerosolized by the powder that's used to lubricate the latex gloves, in those days, cornstarch powder. And the cornstarch powder, while it's a very effective way of spreading the allergen, tends to be relatively heavy. There was an approach that we used early on of having your sort of repeat cases, the spina bifida cases, the genitourinary cases, the neurosurgical cases that would require repeat procedures, to try to get them in as the first procedure in the morning so that the OR would have been well cleaned at the end of the previous day, and any residual latex allergy would have settled to the floor and wouldn't be aerosolized quite as much. The idea of making a space latex free was quickly realized couldn't be achieved. And what the anesthesiologists adopted as an excellent surrogate for that was latex safe, that we were going to do as much as possible to minimize exposure to latex and take both administrative steps and practical steps to reduce latex exposure. That also put a pressure on the glove industry to generate products that were going to be safer. And that pressure worked, both market pressure and, frankly, legal pressure from lawsuits to make products that had a lower latex content, a lower latex protein content. There's an argument to be made, and it's either true or it's not true, and I don't know, but there's an argument to be made that in the rush to make enough latex gloves and barrier products to feed the market in an era of universal precautions, gloves were going from manufacture to use much faster. The gloves that we had in those early days were much higher protein content than they had been before, and that they were subsequently after some tweaks were made in the manufacturing process.
You mentioned there are different types of latex allergy. You talked about the contact dermatitis that was probably the first recognized type of reaction, all the way down to IgE mediated. What are the questions that we should ask our patients when we're thinking about could this be a latex allergy?
Yeah, I think that's a very important thing to talk about because ultimately our best tools are still our history taking tools. Latex allergy, that's a contact dermatitis type reaction, is first of all limited to the skin. And it is usually quite dramatically limited to the area of exposure. So, for example, and this is not an uncommon event, you will have people who will have a fairly defined area of contact dermatitis in the glove area, in the area where the elastic waistband of their underwear touches their skin. These kinds of geographical reactions are much more typical of contact dermatitis than of IgE mediated reactions. That said, they can often be very difficult to treat, the contact dermatitis reactions, and people can be seriously disabled by them, especially if it's in an occupational setting and they don't have the option of switching over to a non-offending agent. You should note that even non-latex gloves can give you contact dermatitis because they may not have latex proteins, but they may have chemicals in them that will cause contact dermatitis. So typically, that's the pattern that's followed. If the reaction is largely hives, is not localized only to the place of contact, and certainly if it spreads to rhinitis, rhinoconjunctivitis, or wheezing, then you certainly have a red flag available that suggests that it's an IgE mediated reaction.
And then how accurate is the testing? So there's a specific IgE for latex that can be sent. I know there are people that make extracts. What is the best way to test and how accurate is that test?
Yeah, this has been a problem since early on, and frankly, it's probably the reason that I got my job at the FDA, and I feel bad to say that I didn't solve the problem for FDA. Early on, there were, I mean, we're allergists, and if you look, I have a 1950s era allergy textbook that's sitting in my office right now. That's a wonderful book to read for fun. But the back third of it is how to make your own extracts. And this is the 1950s. It's not as though we didn't have commercial extracts available at the time. We did. But I mean, I wasn't practicing in the 1950s, but they did. But there were instructions, very detailed instructions, how to make extracts of different kinds of products that required certain kinds of extraction fluids, other extraction fluids, issues of defatting that were more acute with certain reactions than others. So, you know, certainly there were plenty of allergists, and more importantly, there were academic centers that made their own latex extracts, and they made them out of either ammoniated latex or non-ammoniated latex sources. And they use them both in their allergy clinics, and they use them and they actually distributed them to physicians that were affiliated with these academic centers. There were some private allergists just in their own practices that were making extracts. And the problem with all of these is that they were completely they certainly were non-standardized because there was no US standard, but they were uncontrolled for what their sensitivity and specificity, what the predictive value of a positive test, what the predictive value of a negative test was. Even if you went so far, and several of these places did, as to measure the protein content of your extract, which is a good start, you still don't know that it has the full array of specific allergens that we know can be relevant to people that have latex allergy. So in Europe and in Canada, there were commercial extracts that were available for latex. There were several companies. The company that was most relevant for us in the United States was a company called Bencard in Canada, which provided an extract for for skin testing to American practitioners who asked them to send it to them. Bencard is no longer available. There still are latex extracts available from European companies. But in the United States, we don't have a latex extract, either standardized or non-standardized. There was some effort. Greer and the group at Johns Hopkins generated a latex extract that they tried to bring into the market in the United States through the Food and Drug Administration. They ran up against a legitimate problem, and that is that in the U.S. you really need to provide good data to show what the sensitivity and specificity of the test is to get it licensed, and that proved to be just too hard and frankly too expensive for them. And I was at the agency at the time, and they ended up withdrawing their application for this. So in the United States, we don't have a skin test allergen extract. We do have two different serological tests for latex-specific IgE. As with all serological tests, as with all IgE tests, the real important thing to try to find out is what the array of allergens is that's on the solid phase where they're testing. We don't know exactly what it is. I don't know exactly what it is for these different tests, but studies that have been done with both of them show that they're about 80% sensitive and about 90 to 95% specific. So pretty good, but certainly not great. And I use, in my current practice, I use the latex immunocap as adjunct testing when I'm suspicious that it might be latex. If my index of suspicion were very high, I would not turn away from a negative test. In other words, I would trust my clinical intuition. But if I'm simply covering bases where I'm really not sure what the source of urticaria is, then I would probably take a negative test as being definitive in that case. It's trying to apply Bayesian principles in real practice, and this is something that we all need to do with many of the tests that we run. So I think the specific IgE testing that's available is pretty good, and I think it's an important adjunct to clinical care.
In patients who have latex allergy, it's latex has been taken out of a lot of things, which is great. For the most part, we use nitrile gloves in the hospital. What are the things they really do still need to be very cautious around?
Yeah. Well, again, I'm a pediatrician. I've not seen very much latex allergy in a long time, but I think that, balloons are still a problem. Again, I think that almost all dentists and medical offices are very good at having either switched over to non-latex gloves. They certainly always ask, and I think that these are options that people have. I don't know if they're still used. I haven't seen them with any of my grandchildren, but there used to be something called a koosh ball. Does that still exist?
Oh, I think
That
that's from my childhood. I don't remember that. Or I
Yeah,
don't remember seeing it recently with my kids.
I haven't seen it either, but the koosh ball was a tremendous source of allergic reaction at the time. And look, I think that the market of consumer goods has become so worldwide and so decentralized and so uncontrolled that the idea that one of your pediatric patients might encounter a toy that has a large amount of latex allergen protein is not crazy at all. And I think that's one of the great concerns. I think the medical system has done a really good job at reducing exposure. Certainly, our dentist colleagues have been excellent at reducing exposure. I think that the most likely exposure for children today is at a birthday party or in their own school lunchrooms. So
I have patients who tell me that they can't use certain bandages because they have latex in it, and I think that's largely untrue at this point.
I think it's largely untrue at this point. You know, the FDA long ago tried to institute good labeling of medical products as to their latex content. And again, like all of us, the FDA, and this was not my part of the FDA when I was there, so I can talk about them as them, not me, learned over time that the most accurate way to talk about latex content in medical products is whether you use natural rubber latex to make the product or not. that you couldn't really certify that something was latex free or was latex allergen free, but you could state with honesty as to whether latex rubber products were used in the manufacture of the product itself. There are bandages, I think, that contain latex rubber. For the most part, people have trouble with adhesives. And certainly when I see reactions to bandaging, it's almost always an adhesive reaction. And these adhesives are, have serious allergen content in them, not IgE type allergens, not protein allergens, but certainly chemical allergens. And given that the skin over which a bandage is placed tends to be damaged skin already, that seems like the most likely solution.
And then what about foods that cross-react with latex? We definitely have patients who, say they have oral symptoms with things like bananas related to latex. What are the foods you would advise someone with a latex allergy to avoid?
Yeah, there's a large number of foods, unfortunately. And the good news is that the adverse reactions to the foods tend to be non fatal. They tend to be less serious than the latex reactions themselves. And so there's a degree to which you can alert people that they should be aware of potential problems with these fruits, but that you can suggest ways that they can try them out in a controlled circumstance at home and see whether they're a problem. Kiwis, which of course cause oral symptoms in lots of people who have nothing to do with latex allergy, but kiwis were part of the syndrome early on. Avocados, bananas, chestnuts. The list goes on, unfortunately. And the reason that the list goes on is honest. It's not that people are being crazy or overreactive. There are 15, I think, different latex allergens that have been described, and the cross reactivities are on the basis of several of them. So, for instance, we and the group at FDA found HEV-B5, which is an allergen that has no particular known function for the latex tree, but clearly had significant homology to a kiwi allergen. There are profilins in latex. Obviously, that has broad cross reactivity. There are lipid storage proteins in latex. Obviously, that has broad cross reactivity. So the list, the tables that you'll see are quite broad. It's an interesting question because I think if latex allergy were a growing problem, which it's not, I think component resolved diagnoses could really be very, very helpful for latex because the cross reactivities really depend on which allergen you're recognizing. So I think it is an area that going forward, if there's a resurgence and if there's a clinical need, a component resolved diagnosis for latex probably could be very useful.
And then do we think latex allergy decreases over time? We certainly see this with things like penicillin, alpha gal. We know that kids will outgrow milk and egg allergy. Do we see loss of sensitization and even resolution of latex allergy?
Yeah, honestly, I never looked at it formally. Certainly, and again, I was at Children's Hospital, so I saw mostly kids who were exposed in the operating room, and we never really got long enough follow up to know if they no longer were reacting to balloons at home. I suspect none of these parents ever allowed balloons in the household ever. Certainly among the healthcare workers that we took care of, there seemed to be a decreasing sensitivity. And the problem with that, for an individual practitioner to try to psych that out is that, in the healthcare setting, exposure was dropping. And so, of course, these people were having fewer and fewer reactions. But I certainly don't think there's any reason to believe it wouldn't decrease with time. And I think that that should be the guiding principle that if you have somebody who comes into your office and says, even gives a fairly convincing history of 10 years ago, 15 years ago that they had latex allergy, they should be reevaluated because their lives might be significantly improved by repeat testing.
And is latex allergy growing in developing countries where they may have to use latex gloves because they don't have access to other products like nitrile gloves?
Yeah, I imagine that's the case. I mean, the review articles that I've looked at more recently have focused on developing countries. Again, I don't know the statistics on that, but I would imagine that that's clearly true. That in places where there's more exposure and less ability to reduce exposure, there's going to be continued issues. And I have to imagine that it's still an issue for our occupational medicine colleagues. You know, it's a very interesting situation. As allergists, we all learn about occupational medicine.
Thank you so much for taking the time to be with us today. Are there any take home points you really want people to remember about latex allergy?
Yeah, I think the first take home point is remember latex allergy. I mean, there's a real danger, especially for younger practitioners who aren't seeing it quite as much. It's a very serious allergy. And when you see it, these people really need your help and they really need to be directed in the right direction in terms of what they should avoid. It's an allergy in which our diagnostic ability is not very sophisticated, but that just means that you have to take the time and sit down and ask good questions and figure out what's going on from actually talking to your patients. When you encounter people that have latex allergy, the kind of support you can give them is absolutely invaluable, and it's really really important to get this right, to remember it, not to forget it, and to really offer your services to the patients that have this and try to do the best you can to help them. And again, I think going forward, component resolved diagnoses is going to be useful. And I think my guess is that's going to be available fairly quickly. And that, again, can help guide you in terms of the cross reactivity issues with foods, which I think is very important.
Well, thank you so much.
Thank you. It was a pleasure to be here. Thanks.
We hope you enjoyed listening to today's episode. As a reminder, this podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence based information. Any questions pertaining to one's own health should always be discussed with their personal physician. Find an allergist search engine on the Academy's website is a useful tool to locate a list of board certified allergists in your area. Use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at their website. Please visit quadai.org for show notes and any pertinent links from today's conversation. If you like the show, please take a moment to rate and subscribe wherever you download your podcast. Thank you again for listening.